I'm presenting on the impact of novel care pathways on ED operational metrics. So this is my agenda, fairly standard, so let's get right to it, shall we? So we were approached by a pharmaceutical client who has a treatment, a new treatment for a condition that is generally treated in the emergency department of hospitals, and they wanted to know, does their treatment help the emergency department actually run better? The condition that is treated is roughly around 3% of the patients who present, and the client's treatment has two main benefits. It takes actually less time to treat, and it generally will not send patients to be admitted into the hospital. They'll simply be discharged. So, I think you guys all know where this is going if you're veterans. This is a pharmaceutical client, Sterling Simulations presenting, so you're going to actually get to hear something. Our client is currently wanting to publish the results of this model in peer-reviewed journals. So I can't tell you who the client is, I can't tell you what the condition is, I can't tell you what the treatments are. So if anyone wants to play, name that client, start your engines, all right? But if once we do publish, we will update this presentation on AnyLogic website, etc. So, problem statement is very simple. If EDs, emergency departments, switch from the current standard of care treatment to the new treatment by our client, what is the operational gains for the emergency department? And this was divided into two different areas. One, the operational gains for simply the people who are being treated for this condition, and then for all patients overall. So, it's an emergency department model. What method do you use? Generally discrete-event simulation. We had thought about using a more agent-based model so we get more patient behavior. However, the client expected us to do a very extensive data or literature review for the input data, and therefore we weren't able to really find a lot of ABM information. So we decided to use discrete-event simulation. Having said that, to make sure we had agent-based modeling as an option in the back pocket, and because we are very familiar with AnyLogic, we chose to use AnyLogic as a simulation platform. So we have a discrete-event model. So the model can be put into three parts: the process flow, the patients, the entities, and the resources needed to move them through the process. We'll also be discussing the three treatments that were modeled, because those have very drastic impacts on the importance and stuff. So some basic assumptions of our model. Diagnosis is infallible, so the doctors never misdiagnose anyone, all right? And for the condition we're talking about, that's pretty self-assured. The clinical effectiveness treatments were exactly the same. We didn't model really, did you fail the clinical treatment, except for the fact of whether or not you had to be admitted into the hospital or not. Also, since we're doing discrete-event simulation, obviously the entities, patients can't decide to just leave unless we modeled that statistically, which we did, and they can't do other things. And also, the patients could not develop this condition if they didn't have it when they entered the ED, all right? So the entities were patients. The patients generally had a host of lesser conditions, but three major ones. Did they have the condition or not? Were they considered acute patients by different acuity levels? And how long were they willing to wait before getting a bed? Because if they don't get a bed a certain amount of time, they'll just leave. So those parameters are we mainly consider them independent, except for the fact that if you were acute, you would never leave. You'd always stay for treatment. So the resources we got from our lit review were, as you can see, we had registration clerks, triage nurses, different numbers of ED nurses by shift, and physicians. We had 21 beds and 6 observation unit beds. There we go. So there were basically 3 major things we did. First, we created the patients. We did this separately from the rest of the flows for variance reduction purposes we'll discuss later. We have the pretreatment, which is basically until you decide, okay, what do you have and how do you get treated, and then we have a treatment process. All right. So the patients presented, according to a Poisson non-stationary process, about 4 patients an hour. That comes out to about 35,000 patients per year presenting to the ED. 10% of patients were considered acute. 3% of them had the condition, more or less. And by the way, all of these could be user modifiable, obviously, in the interface. And patients willing to wait a very low amount of time, but quite literally, our lit review said that 32% of patients would be willing to wait forever, which I didn't exactly believe, but that's what we had. So 68% leave without being seen rate was the absolute maximum you could see in the model. And here on the right, you can see that that's the basic, high-level steps of the pretreatment process, basic registration, triage, et cetera. For acute patients, they would get a bed immediately, and they don't really go through registration and triage. And we decided once they were assigned a bed, they would no longer be willing to leave until before they were being treated. So the treatment process itself was split into two parts, whether or not you had the condition or not. So if you had the condition, it was modeled very, very low level. This is exactly what happens over time. And that was basically based differently by treatment. If you didn't have the treatment, we sent you through a basic, one block. This is how long you're going to take for your treatment. And this was a major concern. Anybody who does discrete-event simulation knows that this is a huge validation risk. Because if this isn't right, you're never going to validate your model. So we were concerned about that, but we'll discuss that just a bit later. All right. So the treatments. There were 3 treatments we looked at in the model. The standard of care treatment, the client's treatment, and a competitor to our clients and their new treatment. So they differed in various aspects. The standard of care treatment was very low cost, virtually zero. It had a moderate infusion time, but it could lead to further time needed for observation or admission into the hospital. And reducing hospital admissions is a key proponent of any ED. Our client's treatment had very high cost. It had a short infusion time, and it would always lead to discharge. Whereas the competitor's treatment had moderate cost. It had a very long treatment time compared to the others, and it would also generally lead to discharge. Okay, so we built the model. It was fairly straightforward to build. The validation, Sterling retained an ED physician with over 20 years experience to look at our model output and say, is this right? Our client also had an internal review team. But notice, we're Sterling Simulation, we're simulation experts, our client's pharmaceutical company, neither of us are ED experts, so we had to get outside help for validation. And we've mainly validated to the total length of stay in the emergency department and what was the leave without being seen rate. From a, thank goodness perspective, the generic non-condition treatment process needed a bit of calibration. Once we did that, basically we originally modeled it as a triangular distribution, but we needed a much longer tail because obviously that would be needed. But otherwise, it actually validated fine to those metrics. All right, great, we got a valid model. So now we have to start getting production runs done. So to gather the data for answering our business question, the model run was set for a year, and because ED is the poster child for non-terminating discrete-event simulations, we needed to have a warm-up period so that we didn't have weird effects. And also, as I said before, we modeled 2 treatments at a time. One run was 2 different treatments, generally the standard of care versus one of the other treatments. And we sent the exact same patient stream through both of them, which is why we had the patient creation separately, so that the differences in the patients coming into the model would not be a source of variance for what we were looking at. These are the metrics we looked at. So we looked at throughput, which is basically the total number of people who were able to exit the model, total length of stay, throughput rate, and we'll discuss the difference between that and throughput in a minute, total waiting time they had, the leave without being seen rate, and those two are very highly correlated, the admission to the hospital as a check, that was more of a check to make sure it was working properly, and all the various resource utilizations. So, throughput, when we first ran this, we got our runs, we did the regression analysis, et cetera, throughput didn't change. This is weird because length of stay for the patients who had the condition dropped dramatically, as you might expect. But the actual number of patients who went through the model didn't change. And we were like, well, that doesn't make sense. And then we realized that, well, the hospital is basically treating everybody. So the number, basically you send 35,000 people in, you get 35,000 people out. So when we increase the demand, the number of people patients, you definitely start seeing differences. But to actually look at this, we developed throughput rate, which was basically we normalized the number of patients who leave the model by the total time they took to be treated or being in the model. And that, at that point, we saw a much better inverse correlation between those two statistics. And here's the key condition. We found out that by switching the people who had this condition's treatment from the standard of care to the new treatment, every single patient's length of stay on average would be reduced by 10%. That's just show-stopping. When we showed this to our validation expert, he was like, if this is true, which we believe it is true, every ED in the country should do this. Because length of stay for hospital is one of their do-or-die metrics. And we'll see a little bit later. But if you can get back to being non-performant, in other words, your length of stay is too high on average to one where you are, this means a lot to them from an operational perspective. But, there's a cost here. Our client's treatment was much higher in terms of cost than the standard of care. So we looked at a cost-benefit analysis. And lo and behold, when you looked at the cost per improvement in throughput rate, the client's medication and the treatment was actually superior to the standard of care because of the cost it took to just operate the hospital. And otherwise, you can make an argument. Oh, well, it's going to cost you this much per patient, but an extra so much per patient, but you'll get this part of benefit. We have all those metrics as well. But the one that was the throughput rate, it actually is even better. It performs better. Basically, to do numbers, the client's treatment cost about 4 times as much as standard of care, but they got people out 5 times faster. So, And also, these costs are reimbursable. We looked at the charge codes of various treatments in the model, and so that has a big effect on your summary. So, the client's treatment improves for the group that is treating it. They're treating improves enormously. I mean, this is just an absolute no-brainer. But as I said, also especially for length of stay, it affects everyone who goes to the ED. And this was, if I had a mic right now, I'd be dropping it. This is exactly the case we have here. And the competitor is basically lower cost, but doesn't have the same benefits. All right? So, basic conclusions. If an ED is relatively confident that it will actually be reimbursed for the treatments it gives, you should switch the treatment because at that point you're looking at pure operational benefits. Whereas, and also, if the metrics for the ED they're really suffering from, their pain point is length of stay or ED bed utilization, then switching to the thing may be cost beneficial to them as well. The competitor's treatment is not recommended if you're suffering from crowding. Because if you're getting crowded, you're having more people leave, and because the competitor's treatment has a much longer treatment time, you're tying up beds and it exacerbates those conditions. So, in essence, what we built for the client was a sales support tool, and that's exactly what they wanted. They wanted a tool that they could give to their salespeople, and thanks to the wonders of AnyLogic Cloud in 8.3, they can go into hospitals on tablets and say, oh, how's your ED operation? What's your metrics? What's your inputs? Okay, put them in there, run the model, and show what the benefit would be if they use their treatment. And that's exactly what they plan on doing. So I also have a few just slides of not the production model, but the actual, this is what we use to verify things. So, this is mid-run. I know it's very hard to read, but on the left you have the client's treatment, and on the right you have the standard of care treatment. And so you can see it's very difficult to read, but this is the mid-run and this is the end of run. You could switch between overall and per patient metrics. But you have basically you can see it's about 20 minutes lower length of stay for everyone, and you have very different distributions for these other things. So that's basically my presentation. I think I've gotten us back on track, so yay. Are there any questions?
I would think that EDs would have a lot of seasonality, like with flu season looking probably a lot different than summer. Did you guys look at how this performs over different times in the year, or how did you pick your time period that you were going to focus in on?
So what we did, we again, as I said, we did like a 3-month lit review period to look at the data. And the data we got had some seasonality to it. But the main thing we did was, and there's much variation over the course of the day, obviously. So what we did though is we did a lot of sensitivity analysis I didn't really talk about. And most importantly, when demand increases, the relative benefit of the client's treatment of standard care increases as well. Because if you can get more and more people out, faster, the worse your situation, the better you do. So, I mean, that's what we looked at. We didn't have lots of great data on seasonality, but we did try to look at the impacts of various differences. Right? Thanks, Amy.
You said that the average length of stay for all the patients went down.
Yes.
By how much, and what's your analysis? So how did you use the model to identify why did that happen?
Well, okay, so what happened is what we did, we examined it, we looked at different causes, and what it turned out to be is that since the patients with the condition, these patients generally spend a lot of time in the ED, and they take up a bed for a long period of time, either in the ED itself or in the observation unit. So what would happen is that if you don't go to the observation unit and the actual treatment is shorter, you're basically freeing up beds. So one of the issues, as I said, the ED bed utilization went down quite a lot, and that seemed to be the reason that the throughput and therefore, throughput and length of stay would actually, start changing over time. So that's what we looked at mainly, but we also looked at sensitivity analysis for if you change the number of beds, what happens? So the interesting part is that the input data we received was very reasonable. This is the actual ED inputs for a hospital. So when you start changing them, you'll find out that changing these have to be correlated or you start breaking things. And so what happens is the changing from the standard of care to the client's treatment actually basically increases sort of artificially the bed capacity of the ED, so you're getting people through faster and they're not having to wait as long. So that's what happened. And generally it had to do with the treatment length of the different treatments we were looking at.
And what was the reduction in length of stay compared to the average length of stay?
The average length of stay reduced by about 20 minutes. It shows here, it's basically from about 4 hours and 10 minutes to like 3 hours and 50 minutes on average, but that changes, some other ways as well. So that was basically what we looked at in terms of that.
Thank you.
You're welcome. Someone up here? There we go.
I come from a healthcare background.
Excellent.
We have lots of hospitals. One of the things that we found is whenever we propose such process change, there is tremendous hesitancy because they've now begun to be aware that EDs, just like hospitals, are very complex ecosystems.
Yes, they are.
Did you guys do any study of what implication your proposed change, how will it impact the larger ED ecosystem?
So we did look at that. We mainly had our retained ED physician look to these points, but the real point here is that, again, we weren't working with a hospital or emergency department itself. We were working with a pharmaceutical company, and they had sort of different objectives. But we did start asking, okay, how is this going to affect things? So one thing it will do is it will reduce the use of the observation unit by these people with the condition, which means we'll free it for others. So just an example, I believe the #1 use of observation unit beds right now is like for heart problems, cardiac problems. And so that would happen then. The main concern is, again, this model is built for business purposes, and normally I find hospitals have a very sort of dual command structure, if you will. They have the clinicians, the physicians, and then they have the business guys. And we didn't really look at, well, if we show this to the business guys and they try to impose something like changing treatments to the clinicians, what would happen? That would be mainly handled on the clinician side by direct marketing from the pharmaceutical company to explain, this is a better treatment. The clinical parts is pretty much not disputed. So we were looking at more the operational side. All right.
Thanks. Thanks, a very interesting presentation. I wanted to ask you, how did it work with the validation part that you had at the beginning? What was the parameter, or what were the parameters that were looked at in such a way that you say, yeah, this validation makes sense, is statistically significant, and this is going forward?
Right. So mainly the validation we did was, we didn't really do full statistical validation. We did more face validation because the data just wasn't there. Again, we're not working, if I was working with a hospital directly, I'd have their actual data that I could validate to. So we basically did a more or less face validation. But the main parameters we looked at for changing was the input parameters that our validator, our physician was looking for was what's the patient to bed ratio, what are these other things looking at in the input side. The output side we looked at mainly length of stay and leave without being seen rate. So the reason we looked at length of stay as a validation parameter or output was because that was where we expect to see benefits. And therefore, if we don't validate to that, it's not really useful. It's very much GIGO. Length without being seen was something that is a well-known issue. And if you don't get that right, then the pretreatment of treatment is going to be completely, have complete problems trying to get it to work. So those are the main ones we looked at. But it also was very close on terms of bed utilization and other resource utilization, which was also important because we don't want to cause problems for all the, nurses and physicians, et cetera. All right? Thank you. All right. Any others? All right, well, thank you so much.